Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMFS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another episode. Today I'm with Dr. Harkaran Rana. He is an oculoplastic surgeon and fellow, currently practicing in Denver, Colorado. Harkaran, thank you so much for joining us again on the podcast.
Yeah, I appreciate it. I appreciate you having me. I'm happy the last one went okay enough for you to invite me back.
Oh, for sure. Yes, love talking with you and your expertise in some of those areas that maybe we're not as familiar with, or at least some of our listeners, being residents, dental students, maybe aren't quite in that realm. So it's good introduction to some of these topics. So today we wanted to talk a little bit about NOE and frontal sinus fractures and treatment and repair and all that stuff. Can you kind of kick us off on the initial, diagnosing of these issues?
Yeah, totally. I just want to say, I feel like if I want to get the reps in on a surgery, I should just ask to be on the podcast because we had 3 or 4 come in this week right before this. So it's near and dear to my heart, very fresh for me. We know it as the Naso-Orbito-Ethmoid fractures. The central consideration to these fractures is the medial canthal tendon, but we'll get into all that as we talk about anatomy. Typically, they make up about 5% of all facial fractures, and they are on the decline overall with the advent of better seatbelt technology and airbag technology. I hear from older surgeons that they've gotten less and less common as the airbags have gotten more and more common because people are having less straight impacts onto their steering wheel. But there are other methods where you can get them, like a softball to the face or just falling straight in the face, syncopal episodes, things like that. When we're thinking about the anatomy, I think I should just jump in there. The NOE complex consists of the nasal process of the frontal bone, frontal process of the maxilla, lacrimal bones, which sits anterior to the ethmoid bone in the orbit along that medial wall. And then as we continue posteriorly along the medial wall, we have the sphenoid bone, or an arm of the sphenoid bone. The mnemonic that we use in optho for our boards is SMELL, sphenoid, maxillary, ethmoid, lacrimal, for the medial wall of the orbit. And that also helps because it's by the nose, so it should make sense. Remember, the lacrimal bone will house that lacrimal system, so you can remember that being more anterior to the more posterior ethmoid bone, which has all the ethmoid bullae, sort of like airbags for the face. For vasculature, the relevant vasculature that I think about are the anterior and posterior ethmoidal arteries. So when we think about those arteries, they emerge from the frontoorbital suture line along the medial wall. This isn't a hard and fast number, but typically we think of the anterior ethmoidal being about 21-ish millimeters behind the lacrimal crest, the posterior ethmoidal being about 14 millimeters behind that, and then the optic nerve 7 millimeters behind the posterior ethmoidal artery. So some people call that the rule of sevens: 21, 14, 7 as you march back in the orbit. In one way, you can consider the angular artery when you're working these fractures, depending on your approach, like if you're doing a Lynch incision, which I could talk about later. But overall, not really thinking too hard about the angular artery in these surgeries. And all the other anatomy is going to be relevant to the surgical approach you choose. And the big nerves that we're thinking about in the area are the supratrochlear, supraorbital nerve, if you're flipping a coronal. And of course, V2, if you're doing a vestibular or gingivobuccal incision, going from an inferior approach. And after we get through bones, vessels, and nerves, we think about the medial canthal tendon, which is kind of central to everything. The term central segment comes from that original Markowitz and Manson paper in 91, where they deemed the central segment of a comminuted NOE fracture as a segment that has the medial canthal tendon attached. That's what they quote in their paper. So it's sort of what it's referred to when we're thinking about surgical approaches. Once you get the page on somebody, typically we're arriving, we being like the facial trauma team, facial plastics team, are arriving to see the patient after they've been stabilized, and they're typically have a neuro check to see if we need to roll them back to surgery now to stop any bleeding, or if neuro has to do something first. So of course, make sure that's all in order, airway, breathing, circulation, all that sort of thing. But once those boxes are checked, first glance, just take a look at the patient. How swollen are they? Can you get anything done right away? Is this NOE involved in a blast injury where you have to address the soft tissue envelope? Think about when you're going to roll this patient back. If they're super swollen, you're probably not going to be able to do much at that time because mid-face is already a tight space to work in. So that's always a consideration. Do they have any wild lacerations that are going to aid in your approach to the fracture segments? That's always helpful. On Friday, we had a devastating blast injury where a nitro tank exploded in this patient's face, and it was a complete like predator level degloving to the face. So everything was right there. Access was easy, no coronal necessary. Our whole goal at that standpoint was to restore some of the facial skeleton so that we can, and the soft tissue envelope, so that we can build custom plates for later, but that's neither here nor there. So after looking at facial swelling, any lax, next thing you want to pay attention to is the medial canthal region. Do they have telecanthus? When we think about the intercanthal distance, the average is about 30 to 32 millimeters. Of course, this is race dependent, and there aren't a lot of studies showing the differences in race. There's like one out of the 90s showing that African Americans have about 34 millimeters of intercanthal distance, plus or minus 3 millimeters. So that puts us right in our other range. So it's neither here nor there. Looking at an old picture, if they have one, is helpful to gauge where you're trying to land that medial canthal tendon. But amidst all the swelling at the time, things are going to be challenging to assess all at once. Another test you can do for the medial canthus, it's on the AOCMF surgical atlas, is the bowstring test. That's where you stabilize the nasal bone, or just the bones in the nasal region and the medial canthal region with your finger, your thumb, and you grab the lateral canthal angle with fingers. You can pinch it or just try to stabilize it, and then move the lateral canthal angle laterally. Ideally, you should feel a hard pullback on the medial canthal segment. You should feel some resistance. If the other side's not affected, use that as a reference point or try it on yourself. You'll see what I'm talking about. But if it's completely dehisced, it'll be extremely mobile, or if it's a really comminuted fracture, it'll be very mobile. So that's just something that's worth documenting, or that may help you assess the images a little better. That's kind of all I do for telecanthus. Then we're looking at the globe. You know, if they're awakened with it and you can get an eye exam, great. Assess EOMs, extraocular motility, assess pupillary function. You know, if the pupil is moving, then the retina is seeing some sort of light. Even if they're saying they can't see, at least you know there's some sort of light being received by the retina, and you can go from there. If they're asleep, still assess pupillary function. That'll be more difficult depending on what type of medications they've been getting to be sedated. So that's how I would do a quick eye exam. If they are asleep, you can consider forced seductions before rolling them back, just to see if they have any restriction. And of course, correlate everything you're doing on the exam with the imaging you see. We're going to get non-con CTs to assess the severity of the fracture, 3D recons to help with surgical planning and approaches we're going to use. In these fractures, they are hugged up against a lot of adjacent anatomy, like the orbital floor, the anterior skull base. So we are looking for CSF leaks in these patients. You know, the whole beta-2 transferrin is a test we can get, but that takes a while to come back in a lot of institutions. You can use the halo sign, you know, drop of blood and then see if the CSF creates a halo around that drop of blood on like a gauze or a chuck pad. To be honest, I've never tried it, but if the anterior skull base is very disrupted, I'm talking to ENT, I'm talking to neurosurgery to say, hey, can you look at these scans, see if you need to join us, if we need to do anything to address the CSF leak. Any questions so far or anything for me?
No, I mean that's a good review of some of the basic ways to assess the trauma that's going on there, the swelling, the MCT, if it's loose, all that type of stuff, the globe.
Okay, perfect. Yeah. If it's a really devastating injury, it's not a bad idea to get your ophthalmology team on board just to clear the globe. Medical legally, you want to have their name in the chart, making sure that you're doing the best for the patient to take care of them and not miss anything. Because I know we all get excited and focus on the fracture, me, myself included. I like that way more than the eye exam, but sometimes I have to slow myself down and do the eye exam. Then moving on to injuries, for an NOE fracture, it's of course going to be a disruption of that NOE complex. And I've only rarely seen it in isolation, where the NOE complex is an isolated fracture. Usually I see some sort of adjacent injury, whether that be the orbital floor, nasal bones, lower down the piriform, superiorly the frontal sinus being crushed, whether that's anterior table, posterior table, or both. So always look at the picture as a whole. Again, I've rarely seen it as an isolated segment, but that doesn't mean it doesn't happen. And by looking at imaging, that's where you start to think about your Markowitz-Manson type criteria. So you have your Markowitz-Manson type 1, which is that one big central segment with an attached medial canthal tendon, just like one big en bloc fracture. And in that paper, they have good drawings of the 1991 paper by them. They have good drawings of these fractures. A type 2 Markowitz-Manson is a comminuted fracture with attached medial canthal tendon to bone. By convention, again, that segment where the medial canthal tendon is attached is the central segment. A type 3 is a very comminuted fracture with complete avulsion of the canthus. So sometimes it's hard to delineate type 2 or 3. I would just assume the more comminuted, the more likely it is to be a type 3. But your surgical approach for a type 2 or 3 is typically the same in terms of approaching it from superiorly. And then transitioning to when we look at frontal sinus fractures, we've covered the NOE fractures, what they look like. To look at frontal sinus fractures, if it's a minimally displaced anterior table fracture, whether in isolation or in conjunction with an NOE fracture, you don't really have to go chasing after it, unless it's causing a large cosmetic deformity, or if you already have a laceration in the area that's going to give you easy access, you don't really have to go chase at it. So let's say it's a type 1 that's displaced enough where you want to operate, and a minimally displaced frontal sinus fracture. You could leave the frontal sinus fracture alone, unless it's causing a clear cosmetic deformity, but then it'd probably be more displaced and warrant being addressed. The next thing when looking at frontal sinus fractures is looking at the nasal frontal outflow tract. So you want to see if it's involved, if there's a lot of mucus or blood clogging up the sinus and not easily drainable. That outflow tract, you want it to be patent so that fluid can keep flowing out and you don't develop a mucocele long-term postoperatively. So that's what we think about when we think about looking at the nasofrontal outflow tract. Is it involved? Is it disrupted? If so, you may want to do a joint case with ENT where they run an endoscope up there. Or if you're going to flip a coronal for a more involved frontal sinus fracture, like a posterior table fracture, that's going to be something you consider. So when we're talking about a posterior table fracture, we're thinking about, is it largely displaced, minimally displaced, or just completely shattered? If it's largely displaced or completely shattered, you're probably going to end up cranializing that sinus. And that's a joint case with neurosurgery. You're taking off the anterior table, you're taking off the posterior table, you're flipping a pericranial flap inside, and then closing the anterior table on top of it. Dr. Jenser on your podcast had a good episode talking about lifting a pericranial flap and doing all that. So I would tell anyone who's listening to go check that out if they haven't already. If the nasofrontal outflow tract is severely obstructed and ENT thinks we're probably not going to be able to restore it or get any patency, it's good to obliterate the sinus at that point. That involves removing the anterior table, debriding all the mucosa outside of the frontal sinus. You can do that with a bovie. You can do that with a drill bit on high. Don't really have to irrigate it. We want to burn off all the mucosa so we don't develop a mucocele down the road, 10, 20 years down the road. People have reported seeing these. And then plugging the nasofrontal outflow tract from the top, which again would involve more than likely a coronal approach or a large existing laceration. Plugging the nasofrontal outflow tract with whatever you have access to, whether that's pericranium, temporalis muscle, fat, bone chips. There's multiple things that people document doing. I don't know of any big studies that show one is better than the other. If somebody does, it might be best to post in the comments of your Spotify for this episode. But me personally, I don't know if one is definitively better than the other to obliterate the sinus.
When you're trying to determine the patency of the nasofrontal outflow tract, I mean, is that all just based on the CT scan, or how are you looking at that?
So a CT scan is helpful. You can also consider, if you have it open, you can always consider flushing the sinus to see if anything comes out in the nose. Obviously, you'd be looking up the nose with the endoscope. or you can have your ENT colleague drive an endoscope to assess the patency of it. They often are going in there to do balloon dilation, so they're comfortable with the anatomy. They know what's pain and what's not. Me personally, I can't just tell without a CT and an ENT consult. But yeah, to review what I talked about, so it sounds a little bit more concise. Looking at a frontal sinus fracture, is it affecting the anterior table, the posterior table, or both? What is the severity of those fractures? And is the outflow tract involved? If so, how severe? Depending on severity of these fractures, it will drive your decision to plate, to cranialize, or to obliterate the frontal sinus. So it's all a tier level thing. And, usually you're working on these cases as a team. So you have, it's not just going to be you making every decision. Usually you're bouncing ideas off of each other, whether that be with ENT, neurosurgery, or facial plastics. So that's pretty much all I have for that and for the types of fractures and going through what you're looking at on imaging. But as we're going through the treatment and management, looking at, I'll bounce back to the NOE fractures. Looking at a type 1 Markowitz-Manson fracture. In that paper in 1991, they did say that you can plate some unilateral minimally displaced fractures through just the vestibular or the gingivobuccal incision. I know people call it different things. You can plate it just through that, one plate on the orbital rim, one plate on the piriform, as long as there's not this big internal rotation, which kicks the posterior aspect of the orbit into the orbit. Then you don't really have to go opening up everything else. As long as you can get that stable, those fractures are mobile, you can do that. If you want to address the superior aspect of the fracture and put a plate somewhere on the nasal bones and the frontal suture, you can do a direct cut down on there, a glabellar incision or a Lynch incision for that. But in their paper, they say that usually a piriform plate and a orbital rim plate can be sufficient if it's minimally displaced, or you can just observe to see if they're having any issues long-term once the swelling goes down. Obviously, you guys do tons of those incisions for your orthognathic cases, so I don't feel like I have to go through the vestibular incision steps or approach. So I'm just going to leave that alone. Typically, plates in this region, we're thinking about using 0.7, like a pink plate in the Synthy set, a 0.7 millimeter plate, and 4 or 5 millimeter screws. We'll use like a 6 millimeter drill bit, 6 millimeter stop, and just nothing special, nothing that you guys don't already work with a lot in this region. On the rim, only consideration is a low profile plate. On the piriform, maybe make it a little bit more stout. But that's all I would say about the type 1 fractures that are large, minimally displaced, non-comminuted. As long as they're mobile through that incision, you can get away with doing the least. As we get to type 2 and 3, Markowitz-Manson fractures, those are the fractures that are more than likely going to involve adjacent structures, whether that is the orbital floor, the medial wall being more devastated, the frontal sinus, anterior posterior tables, nasal root, nasal bones. That's where we have to start thinking about the coronal incision. Again, I'd reference Dr. Genzer's podcast on here to go through that in depth. He mentioned in that podcast the pericranial flap if you're going to cranialize the frontal sinus. He mentioned what to look out for in that dissection in terms of nerves. And I do believe he touched upon like the supraorbital nerve and supratrochlear nerve being really important as you go more inferiorly. So there's something I really have to hit on more there. I will offer an alternative to the coronal approach. You can use a Lynch incision nicely in these cases. If you do a little cut down and you hang a Y plate posteriorly into the orbit, you can grab the medial canthal tendon and hang it on the deep posterior aspect of that Y plate, because the whole goal of hanging a Y plate, or the whole goal of repositioning the medial canthal tendon, is to push it as far posteriorly and superiorly in the orbit as you can get away with, to aid in positioning. Let's see here. Alternatives to a coronal, you can do the gull wing incision too, but again, that leaves a really gnarly scar on a patient, so we don't want to introduce new scars on the face that we don't have to. But again, that's where existing lacs can also help you out. Let's see here. Okay, so I think briefly right now I will talk about transnasal wiring, because this is the thing that I've personally had to do the least often because we can get away a lot with plating. And if there's big enough segments where the medial canthal tendon is attached, we don't really have to do it too much. But if you get a type 3 injury, you're going to have to, or even in some type 2 injuries, that piece of bone that the canthal tendon's hanging on to isn't really viable. So we have to detach it anyway and create a type 3 effectively. So there's different ways to do it. You can use a wire with a barb attached to it to grab onto the transnasal wire, or to grab onto the medial canthal tendon and pass it through transnasally. Or you can use like a large 2O PDS suture to secure the medial canthal tendon and pass it transnasally. Regardless, unless there's a large defect on both sides, you're going to have to drill a hole transnasally. And you want to go, again, as far posteriorly and superiorly in the orbit as you can when you're placing this transnasal wire in this drill hole. So typically, when you flip down a coronal, you want to identify the medial canthal tendon first, grab what you think it is on the inside of the flap, verify externally that you have it in your pickups in a good position, try to pre-place it with your pickups in orbit, see where you think you're going to go, get it in your mind's eye, then get a drill, maybe a 12 millimeter drill bit, just something to get all the way through and have malleables to protect the globe, of course. Once you get that through, secure your medial canthal tendon, pass it through there from the affected side to the contralateral non-affected side. If it's bilateral, you're going to have to do this bilaterally. And then I would reference the AO surgical atlas. They have a good picture of it. You can hang a screw on the frontal bone on the contralateral side of the medial canthal tendon you've secured in the medial brow region and secure the wire or your PDS there so that it is traversing posteriorly and superiorly in the orbit, transnasally, and then it comes posteriorly to anteriorly on the contralateral side and secured to the contralateral screw. Me just describing that already sounds convoluted. I confused myself there. So again, I'd reference that picture hardcore. But yeah, that's those are your options to secure the medial canthal tendon and put it in a good position. The biggest mistake that people make, and it's really easy to make, is just not getting it as far back as possible. If you feel like this is the first one you're doing in a while, try to get someone who's done more than with you because it's very nuanced, as I've learned in my time here. And if you're not getting them often, but you want to start getting back into them, I'd recommend going to one of those AO courses. The AO Orbit course is sick. That's where I really got a lot of practice with this before I started doing them live, like in the OR.
Nice.
Yeah.
Which types of fractures do you see the most? I mean, are they usually type 1 or are they usually comminuted? And what is your experience?
I would say they're usually in our trauma group out here in Denver, they're type 2. We're getting a lot of MVC accidents and like high impact accidents. We're not getting like the typical I fell or softball to the face, which tend to be a little less devastating. That population who's getting the softballs to the face have just better bone stock. People who are getting these accidents are typically have worse bone quality, and I'm seeing a lot of type 2s.
Okay.
So for the most part. In terms of frontal sinus fractures, we get like a lot of just non-op observation frontal sinus fractures. I've had maybe 8 in 2 years here. Going on 2 years here, I've had maybe 8 or so frontal sinus cranializations. So it's not too common that the posterior table's so destroyed into cornflakes that we have to do something about it. But that's in regards to the frontal sinus. But usually the most common fracture this is anecdotal, of course, that I'm seeing involved with an NOE fracture of any kind is orbital floor. We always have to pop in a plate on the floor, it seems.
Okay. And a lot of these are older patients who, fall, pass out, hit their face on a fall, usually.
Yeah, like it's a sinkhole episode, so they're not like turning their head away or trying to avoid a direct facial impact. From certain hospitals around here where it's more the knife and gun club, we do see a good amount of more vehicle-related NOEs, which are much more high impact and high velocity injuries. And that probably comes from, the airbags probably not working as well in those cars, but yeah.
Yeah, got it.
That's sort of all I can think of off the top of my head for those fractures, how I go through the treatment plan and the approaches and considerations. I think the most important thing in terms of cosmesis, it's hard to say that one thing is the most important because you can argue for all of them, but obviously for the oculoplastics trained first guy, it's the medial canthal tendon positioning. You don't want them to look too simian, or you don't want them to look too pancake faced and wide and spread out. So getting that deep depression is important. Having those shadows there is important. Yeah. I can briefly touch on for a secondary recon, we do get a lot of them. And a good incision for a secondary recon we found is the Lynch incision. Once you make that Lynch incision, we can tunnel back in the orbit. The medial canthal tendon's already attached or in a bad position, so we don't mind attaching it more. Tunnel back in the orbit. if they have a strong nasal root, hang that Y plate, secure the medial canthal tendon to the posterior aspect of the Y plate, posterior being inside of the orbit. And then one thing you can do is start securing bolster. I'll come back to that. But once you close the lynch incision, the scar that develops from that lynch incision creates a natural depression as well as the medial canthopexy you've done with your plate. So that creates a nice shadow line that you see in the medial canthal region naturally. So incision design helps a lot there. When I talk about the bolster, we do this in almost all NOE fractures if we have the exposure. We try to put a compressive bolster onto the medial canthal region once it's all closed, so as to aid in soft tissue swelling and it really sticking down, kind of like how people do compressive bolsters in rhinoplasty when they're doing lateral crural underlay grafts. Dean Toriumi does a lot of those for his lateral crural underlay grafts in his rhinoplasty. You really want the skin and soft tissue to stick down in the medial canthal region so it doesn't just become puffy and bow back out. So briefly, the way that Dr. Willoughby, who's trained me, and I do it, we will, while it's open, we will pre-place a double arm 4-0 silk suture. The 4-0 silk comes on like a G3 needle, and in that packet, they have this piece of foam that you can already use as your bolster, which is nice. So you place that deep, and this is after the canthopexy has been done and you're secured to the plate. You place that to some deep soft tissue, and then you run it through your skin adjacent to your wound edge, close just outside of your wound edge. You close your lynch incision, and then these two sutures are hanging out, and you thread them through a foam bolster and tie it onto the foam bolster. Then in like 2-3 weeks, you cut off the bolster, you pull it right through. If you don't have a double arm 4-0 silk G3 needle, you can use a single arm and use some of the foam out of a Kittner. You just have to place it through the foam earlier. I'm saying this because I just made this mistake where I forgot to place it at the right time. So I had to open it up and redo the order of events because it's a single arm suture. So just remember where you're going to be tying at the end of the case. Place it through the foam first, deep bite of soft tissue, periosteum. Have it, or I should say, foam bolster through the skin, deep bite of periosteum, back out through the skin, close your lynch incision, and then close the bolster. This compressive bolster, it seems it's pain to do, but we found it really helps with soft tissue attachment to the deeper layers as everything scars down. Because even if we've gotten the canthopexy right and money on the table, if we didn't do the bolster, they still look puffy there. So yeah, their canthal tendon's in a great position and they look better than what they were. But to look even better, the bolster we found anecdotally has been a real gift.
Nice. That's great to describe and help for our listeners. Going back to your placement of the plate, so you're saying you're trying to put that as posterior as possible. You're retracting way back.
Yeah.
In the main structure, are you getting close to or trying not to disrupt is the anterior ethmoidal artery, or what are you getting close to there?
Yeah. Typically the way it's taught is like get as far back as you can. As when you put the plate though, you do want to be the plate or the drill hole. We want to be inferior to the anterior and posterior ethmoidal arteries. That sort of demarcates the skull base. So we don't want to go drilling above that. So you always want to be inferior. That's a great point. You always want to be inferior to that. It's a good time to look at the pre-op scans to see how far down the cranial fossa dips there, because in some people it dips really far down. So you may want to hedge your bets and go even lower just in case. Obviously, if you're doing intraoperative sort of tracking, we don't use that much at all here, but if you're using that, it'll help verify before you're drilling anything, and it makes it a lot easier intraoperatively. But if you're not, just make sure you take a good look at the scans, feel comfortable with where you're going to place that drill, because last thing you want is neurosurgery to get involved when they otherwise didn't have to. But yeah, that's a great point. Staying below the anterior and posterior ethmoidal arteries keeps you in a safe zone, so you're not entering brain. And then above that is a no-go zone for drills and long screws.
And you mentioned that you're usually placing these plates in conjunction with the orbital floor plate because of orbital floor fracture. Is that right?
Yeah. So we tend to see a lot of it is usually seen in conjunction with the floor fracture. So if we can, we will hang one big orbital floor medial wall plate. Sometimes the medial wall isn't comminuted enough to warrant a plate in and of itself. So we can get away with reducing the NOE segment, plating it at the rim level, leaving the medial wall as it is, and just plating the floor with, titanium mesh or, med pore, so whatever your orbital floor plate of choice is.
Got it.
Yeah. I just watched a good video of somebody doing that with mesh around the whole orbital floor, like medial orbital wall to the floor, and, it looked nice. And they used a coronal for access, and it was beautiful.
Wow. Nice. All right. Well, that's helpful. A lot of good resources online, like you mentioned, the AO website and all their diagrams and pictures and discussions and videos. So super helpful. This is really nice to hear you explain it and give your kind of tricks and tips to repairing these types of fractures.
Yeah. Thanks for having me. Hopefully I didn't ramble too much. Sometimes I get lost in my own thoughts.
No, that was great. Real quick, any good books you've been reading lately?
Not reading, but I've been listening to Empire of Pain. It's
Okay.
about the Sackler family. Wild book. I mean, it starts off just learning about their lives, which is insane, and then so I'm slowly getting to the part where they create the opioid epidemic per the book. But yeah, that's a great book I've been listening to right now. And I just finished listening to Shoe Dog about Phil Knight, the Nike founder.
Oh, love it. So good.
So good. But yeah, it gave me a lot of energy.
Yeah, there's a part in I read Shoe Dog a few years ago, but where he's like operating out of his basement, and then he goes and like has these meetings with these Japanese businessmen, and he's just like BSing and making stuff up and acting like he's got this business which really doesn't exist, and
Yeah.
just so insane, like how Nike got started, and it was just like hanging by a thread, for so long. It's wild.
Oh yeah, dude. Fake it till you make it was never so real.
That's right. He's like the originator of that phrase, fake it till you make it.
Exactly, dude. Exactly.
Those are great recommendations. Any shows you're watching or movies you've seen lately?
I'm on the bandwagon of where I feel like we're in the TV renaissance right now. We have Severance, which is just awesome. We have White Lotus, which I'm not a fan of the new theme song, as most people aren't, but White Lotus is good. And then my mindless TV is Traders. It's that reality show that's like that home game mafia.
Okay.
Yeah, it's just mindless, easy TV, but yeah, it's good after a long day.
That's awesome. Well, you guys heard it here first. We're in the TV renaissance, so start watching. You gotta hit your remotes quick. Well, that's great. A couple nights ago, I saw this movie, Last Breath, in the theater that came out. It was pretty good with Simu Liu and Woody Harrelson. It's about these guys who are working almost 1,000 miles at the bottom of the sea, repairing these gas pipelines, and of course some stuff goes down, and one of the guys almost dies, and just incredible story. But watching that movie made me think, gosh, I thought my job was hard and horrible at
Right?
times, but
Yeah.
there's a lot worse out there, folks.
Oh my God, yeah. Yeah, sometimes after a long case I complain and then I think about, nah, this is nothing.
Yeah, could be much worse.
Yeah. Yeah, dude. Can I give a subtle plug for myself?
Yes, please.
Dude, I just want to let the guys know over at Madigan Army Medical Center that I got orders to come out there. So looking forward to working with y'all in the oral surgery, facial plastics, if you listen there too, you guys too. Should get out there sometime in August. So I'm looking forward to it. 4 months of fellowship left.
Oh man, so great. Happy for you. What a long road, but the amount of experience and knowledge you've gained is just tremendous.
Yeah, I feel super, super lucky. I don't think there's a fellowship out there that could have trained an ophthalmologist to spread its wings and fly like this one.
That's right. Oh, so great. Well, thank you so much, Kron, for sharing this content with us. If you're good with it, I can put your email or some type of contact info in the show notes so that listeners could reach out if they have further questions.
Definitely, definitely.
Awesome. Well, good. Thank you again, and have a great rest of your day.
All right, thanks, man. Take care.
Thank you. Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.